are going to continue our session regarding the physiology of the CNS. The first thing to speak about is the neurons. As you remember, neurons were cells that basically do not proliferate. They are a permanent type of cells, like cardiac cells, neurons, and also we have the musculoskeletal cells. So they write, neurons, their function, they are a single transmitting cells of the nervous system. Remember, the neuron contained, well, two main particles, actually three, but for now let's just imagine that we have only two. The soma, which is the body of the neuron, and the axon, which is the tail of the neuron. It's the wire that connects. A bundle of axons inside of the CNS, we call it a tract. In the BNS, in the peripheral nervous system, we call it a peripheral nerve. A collection of soma, which is the body of the neurons, a collection of body of the neurons inside of the CNS, we call it nucleus. And in the BNS, we call it ganglia. It's a permanent cell, which means it does not divide in adulthood. It is always in the G0 in the cell cycle. Signal relaying cells with dendrites which receive the input, cell body and axons. So these are the three particles I told you about. So this is the dendrite which perceive the info, the soma of the neuron, and the tail of the neuron, which is the axon, which sends the output. Cell's body and dendrite can be seen on nasal staining, which stains the rough endoplasmatic reticulum. So when you hear the word nasal body, that's basically telling you this is the rough endoplasmatic reticulum in the neurons. What makes the rough endoplasmatic reticulum rough? What makes it rough? Well, actually, the thing that makes it rough is going to be the ribosomes. It's the ribosomes, guys. Yep. Okay. So you can see here, inside of the neurons, there is these things surrounding the nucleus. This is rough endoplasmatic reticulum, also known as nasal body. Rough endoplasmatic reticulum is not present in the axons. So how can we transmit? Well, the rough endoplasmatic reticulum contains the ribosomes, as you said. So the creation of the neurotransmitter is going to be inside of it because neurotransmitter is a protein. How can we move the neurotransmitter from the nasal body, which is the rough endoplasmatic reticulum, into the axon and then to the pre-synaptic cleft? How can we move it from the soma, which is the body of the neuron, to the presynaptic cleft? How can we do that? Not a tract, no. There is something like no, not a receptor. It's like a little ATP motor enzymes. Dynein moves it backward, but you need something that moves it forward. So remember, kinesin moves it forward, dynein moves it backward. Anterogradely, kinesin. Retrogradely, it's going to be dynein. Okay. So the next thing is going to be something like this. Neurons marker include the neurofilament protein and synaptophysin. Remember also the neuroendocrine tumor, all of them have synaptophysin positive staining. The astrocyte. What is the astrocyte? I like to think about the astrocyte as like the background that everything is sticking. You know, when you wanna build a house, first of all you need to put the foundation. You need to have some type of foundation that you can put on it the structures, right? So the astrocyte is basically, first of all, the main function. It is what makes the bulkiness of the brain. Okay, so all of the neurons are located inside, like around the astrocyte, but the astrocyte is the thing that connecting everything to each other. Okay, so they are the glue that keep everything together. The astrocyte is the most common glial cells in the CNS. It makes up to 50% of all cells in the CNS. It gives the physical support that I just explained for you, and also help in the process of repair and removal of excess neurotransmitter. You are like, wait a second, but you told us that when neurons die, we cannot change them. Like they are gone for good. They will not be back. That's true. That's true. So how can they help in the process of repair? Exactly. It's the process of repair, not regeneration. Regeneration and repair are totally different processes. Regeneration means when you get a type of cell, it dies, and you make the exact same cell. That is called regeneration. Repair, however, it's when you have one cell that dies, and instead of it, you get fibrosis, or in case of the brain, you get something called gliosis. Okay? Also, removal of excess neurotransmitter, component of the blood-brain barrier that will be explained deeply. Don't worry about it for now. Also, glycogen fuel reserve buffer. So what's up? The brain normally utilizes only glucose. However, it contains a small amount of glycogen within the astrocyte that can be utilized in case of in cases of emergency. Reactive gliosis in response to neuronal injury can occur. So as I said previously, there is regeneration and repair. Regeneration, one cell dies, you make the exact same cell. Repair, in the brain, one cell dies, and instead of the cell, you don't have the actual fibrosis, so we say gliosis. It's derived from neuroectoderm, and the marker for them is the GFAP. Okay, so what about microglia? They are basically the macrophages of the brain. So phagocytic scavenger cells of the CNS. So basically you remember the liver had the Kupffer cells, the lung the dust cells, the skin the Langerhans cells, the brain will have the microglia cells. Activation in response to tissue damage, release of inflammatory mediators such as nitric oxide and glutamate. Not readily discernible by Nissl stain. So what does that mean? It will not stain with the Nissl stain. Okay, it's derived. Why? Because it does not contain rough endoplasmatic reticulum. It does not have that. However, it has the nitric oxide and the glutamate. We'll learn more about these two neurotransmitter in the near future. However, you must know that it is the phagocyte, which is the macrophage of the brain. So if you get a weird question, and you will get that, there is something called HIV dementia, in which the patient who have HIV eventually gets dementia. And it's a direct effect of the HIV himself. You know, most of the HIV problems is because of the opportunistic infection, but not this one. The dementia in HIV is directly caused by the virus. Thus, the HIV-associated dementia is totally caused by the HIV virus. And you must know, if they give you a question, where is the HIV located within the brain? We know inside of our body that HIV only can reside in 2 cells. Do you know which 2 cells can the HIV reside in? CD4, that's one of them. What about the other one? The macrophages, absolutely. So in case of the brain, exactly. So in the brain, it's going to be the microglial cells. That's how they ask the question. So the microglia, it's derived from mesoderm, like most other blood cells. And the HIV-infected microglia fuse together to form multinucleated giant cells. What's the giant cells? It's basically like one big cells with multiple nuclei inside of it. When you see something like that, you need to say it's a giant cell. Giant cell in CNS seen in HIV-associated dementia. I want to tell you a little bit between the difference between dementia and delirium. Dementia is progressive. I mean, the patient is here, and his mental capacity start going down, 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 down until he's screwed. But in case of delirium, the patient is here, and in one day, it's here. So as you can see, it happens suddenly. What is interesting about delirium, exactly, it's reversible. So if you treat the underlying cause, the patient is going to go back to normal. In dementia, there is two main reversible causes you must know about. There is more, but these are the two that they love and they use similarly. The B12 deficiency and the hypothyroidism. The alcoholic dementia is irreversible. So, epidendymal cell. The epidendymal cells are the type of cells covering the ventriculi and the CSF system from the inside. Remember, inside of our brain, in each, like, doesn't matter if it was the hemisphere, telencephalon, mesencephalon, it was metencephalon, it was myelencephalon, it does not really matter. All of them has some form of chamber inside of them. If you remember, the lateral ventricles connected with the foramen of Monroe to the third ventricle, which connected to the aqueduct of Salvius to the fourth ventricle. And from the fourth ventricle, we went to the central canal. And also we have the foramen of Monroe and foramen of Magendie, which went to the subdural space. Anyway, all of this ventricular system is covered by epidendymal cells from the inside. So it's basically creating the walls of the ventricles. So the walls of the ventricles are created by epidendymal cells. So if a person has an epidendioma, you will see the mass not inside of the brain parenchyma, but inside of the ventriculi themselves. That's where you can see an epidendioma, which is a tumor cells arising from the epidendymal cells. So it's a ciliated, simple columnar glial cells lining the ventriculi and the central canal of the spinal cord. Now comes the question, why does it have the cilia? Why do you think it has a cilia? I mean, this epidendymal cells. Movement of what? You are right, it's movement of something, but what do they move? Excellent, they move the CSF around. They move the CSF between the different chambers. Okay, apical surface is covered by cilia, which circulate the CSF, and microvilli, which help in the CSF absorption, which can be absorbed into the subdural and then the subarachnoid space, and we'll speak more about it in the near future. Guys, I have a question. The blood vessels in the brain, I mean the ones that supplies the brain parenchyma, are they located in the epidural space, subdural space, or subarachnoid space? Excellent, it's in the subarachnoid space. Now comes the tricky question. The CSF that is circulating, after it goes out from the ventricle, I know that it goes to like near the dura, but eventually, where it's going to accumulate around the brain? Is it going to accumulate in the subdural space, subarachnoid space, or the epidural space? It's a tricky question. It's actually, guys, it's going to be the subarachnoid space. You're like, wait a second. Does that mean that the CSF is going around the blood vessels of the brain? Can we say that the blood vessels of the brain are swimming and floating inside of the CSF? Exactly. So the blood vessels of the brain are swimming inside of the CSF. Why? Why would we do that? Why this is a thing? Why the blood vessels of the brain are swimming inside of the CSF? Good. Good. Exactly, guys. So let's imagine that you got some form like of car accident, okay? You hit your head really bad. So the blood vessels are going to have this fluid around them. Yes, they are going to be shaken, but not ruptured, right? So yes, really bad shake, but will not rupture. That will reduce the risk of rupture. Basically, they work like Cushing's, right? Okay, quite interesting. That's why when you have some type of bleeding from one vessel of your brain, like an aneurysm rupture of one of these blood vessels, and you do a subarachnoid tap, what you will find in subarachnoid tap, you will have RBCs, blood. It will be something called xanthochromia that we will learn about. Okay, so anyway, The epidendymal cells are derived from neuroectodermal cells again. Specialized epidendymal cells are the choroid plexus. Choroid plexus, what was that? Choroid plexus. If someone tell me about it, please tell me where it is. Where can I find it? Excellent. It produces CSF, but where it is located normally? Yes, it's inside of the chambers, mostly in the lateral and the third ventricles. Okay, good. Good. We'll speak more about the details about how this CSF system works. So myelin. Quick. In the CNS, oligodendrocyte lead to myelination of the brain. In the BNS, Schwann cells do the myelination of the peripheral nerve. What I want you to know that the Schwann cells, it goes something like this. You need one Schwann cells to myelinate one nerve. However, one oligodendrocyte can myelinate multiple nerves. That's the first thing to know. All of the peripheral nerves are myelinated by Schwann cells. So let's learn what is myelin, and then I will tell you a little trick about it. Myelin, they write, it increases the conduction velocity of signal transmitted down the axon. How come? Well, basically, action potential will be here, and then like boom, and then jump. The action potential is going to jump. Jump. This jumping movement facilitates the action potential. It makes it much more faster. This area between the two myelination, we call it the node of Ranvier. Really common question that I assure you will see in your exam is, which channel is located at the node of Ranvier? So basically, which channel is node of Ranvier rich of? A channel that can lead to action potential inside of a nerve. It's actually the sodium channel, guys, the sodium channel. Okay, so saltatory conduction of action potential at the Ranvier. So what does that mean? The saltatory, which is a word I really struggle with, it means jumping. It's this jumping motion I just explained. Where there are high concentration of sodium channels. So the sodium channels, it will be like action potential. It will reach here, and then boom, it will go to the next one. And then action potential, boom, next one. And it will keep going. Okay, so in the CNS, including cranial nerve 2, myelin is synthesized by the oligodendrocytes. You're like, wait a second. But I thought that the nerves were BNS. That is correct. All of your cranial nerve and the spinal nerve are considered as peripheral nerves, and they are covered by Schwann cells except two nerves. Cranial nerve number 1, cranial nerve number 2. Does anybody know which nerve are these? Olfactory and not ophthalmic, that's wrong. It will be optic, okay? Ophthalmic is a branch of the trigeminal nerve, branch number 1, V1. But if we speak about the optic, yes, that's true. That's cranial nerve number 2. Okay, so that explains why people with diseases of the CNS only, like multiple sclerosis, can have visual problem and olfactory problem. Okay, so in the BNS, including cranial nerve number 3 until 12, myelin is synthesized by the Schwann cells. Okay, so myelin wraps and insulates the axons. It's like the plastic cover. Decreases membrane capacitance, increases membrane resistance, and increases space length constant. What does that mean? Well, guys, are nerves long? I mean, peripheral nerves. Their axon, is it long? It's pretty long. For example, if we speak about the sciatic nerve, the body of the axon is located within the spinal cord, while the sciatic nerve is like a meter long. That's really wrong. So because it's really long, you need for the signal to come from the back all the way until the end. Myelin facilitate that. What does it mean? Increases space length constant, which means that it eases up the movement from larger distances between the body and the basically effector muscle. Basically, I like to think about it, if you know this electrical station, sometimes when the like the electricity becomes weaker, they have this potentiation circuit, you know, that exactly a relay station that will make the current much more stronger. Yes, and they decrease the time constant. Oligodendrocyte, that will be in the CNS, exactly an amplifier. And in the Schwann cells is going to myelinate the BNS. Schwann cells, myelination stuff. Okay, node of Ranvier, please don't forget about the sodium channel. It promotes axonal regeneration. You are like, wait a second and go back. You told us that the neurons do not regenerate. Yes, I said that. But here you now are telling us they promote axonal regeneration. Yes, I said that. You are like, wait a second. So can a peripheral nerve regrow? What do you think? If somebody got a horrible trauma, can peripheral nerves regrow? The answer is yes. But is it quick or slow? It's super slow. We are speaking about 1 centimeter per 6 months. You are like, wow, that's not bad, 1 centimeter in 6 months. Yes, but let's say somebody cut his sciatic nerve. How long is the sciatic nerve? Around 1 meter, right? Okay, you do the math. How many years he will need for the sake of regenerating him? Okay, you are bad at math. It's 50. Because we said six months, right? So 6 months for 1 centimeter. So if we say 100 centimeter, you need to, so for each 2 centimeter, you need a year. So you need 50 years. Yeah? Let's say he cut it at age 50. It's too late. So yeah, it will regrow, but it is just a humongous amount of time. So why I'm even telling you about that? Because sometimes if somebody like wanted to commit suicide, he cut his nerve, well, he got his vessels, but he might cut his nerves. If you have this nerve like this and you have the rest of it like this, what you can do actually, just put them next to each other like this, okay? So after 6 months or so, this will regrow, okay? You will put one suture here and that's it. They will regrow, they will reconnect with the help of Schwann cells, right? Okay, so that's why it's useful. But a peripheral nerve to grow from zero, that takes forever. Okay, each Schwann cells myelinate only 1 BNS axons. So injury, it can be injured in a disease called Guillain-Barré syndrome. We studied together microbiology. Do you remember which bacteria can lead to Guillain-Barré syndrome? Campylobacter jejuni, absolutely correct. If you remember, that can lead to a paralysis in this disease. And it was super serious. Also, we spoke that other causes of it include Zika virus, if you remember, and orthomyxovirus. You are like, wait a second, is that influenza? Yes. It's pretty rare, but it can happen. So all of Schwann cells come from neuronal cross cells, which means they have a marker that is known as S100. Transverse myelitis we'll speak about later. Oligodendrocyte is the CNS type of myelinating particle. It's going to myelinate multiple nerves at the same time, okay? So one cell can myelinate multiple nerves. Myelinate axons of neurons in the CNS. Each oligodendrocyte can myelinate many axons, around 30. It's a predominant type of glial cells in the white matter. Okay. So it's derived also from neuroectoderm, and what is interesting about it, the oligodendrocyte, remember it's the white matter creating type of cell. So in the brain, it's also around 1 cranial nerve. Do you remember which cranial nerve have oligodendrocyte around it and not Schwann cells, a cranial nerve? Number 1 and number 2, which are the optic and the olfactory. You are like, wait a second, so if we speak about a disease that affect the myelination of the brain, the CNS, the patient will have disturbances in his vision and in his smell? The answer is yes. Even somebody wrote MS, multiple sclerosis. You are correct. One of the main and the first signs of multiple sclerosis in the patient is problem in the smell. Guys, if you cannot smell, can you taste? You cannot. Also, they will have visual problem. It will start with the flashes and end up with the blindness. Derived from neuroectoderm, a fried egg appearance in histology, and this is not the only place we will see a fried egg appearance. We'll see it again in reproductive. Injured in multiple sclerosis, progressive multifocal leukoencephalopathy, which is due to the GC virus in case of the HIV patient, and also leukodystrophies. So let's take a look at the oligodendrocyte. Okay, you can see the fried egg appearance. It's like an egg and around it is white. Okie dokie. So, let's take a look at the neuron action potential. When we speak about the neurons, I will do this, and after that there is this horrible table that you must memorize. So I will leave this to a little bit like after the break, because this is just demotivating. So, because it's just like pure memorization. I hate memorization. Neuronal action potential actually starts as following. It's a little bit different from other action potentials, just keep that in mind. It's not cardiac, and if you remember, in cardiac it was all about calcium, right? Yes, it has sodium, it has potassium, but there was a lot of calcium involved. Here it's not the same. So they write, resting membrane potential is more permeable to the potassium than the sodium. Voltage gated sodium and potassium channels are close. So initially, if they ask you who maintains the resting membrane potential, is it the sodium or the potassium? Who maintains the resting membrane potential? The resting membrane potential, it means the flat line. It's actually the potassium, guys. It's actually the potassium, okay? It maintains the negativity of the membrane. So it's negative. Why? Because the potassium keeps getting out. When it gets out, it gets more negative. So you can see here that that's the first step. Everything is negative, everything is perfect. What is next? Membrane depolarization. Where the depolarization came from, it doesn't matter. Maybe it was an upper motor neuron activity, maybe it was an actual electrical wave delivered to the body. So membrane depolarization will lead to sodium channel activation of the gate, and it will open. When this sodium channel will open, the sodium will start entering. Is sodium positive or negative? Sodium, we say Na plus. Exactly, Na plus. So the plus, that means is positive. So when it goes inside of the cell, it will become more positive, the membrane potential. So it's becoming more positive, as you can see. Membrane repolarization. Sodium inactivation gate closes at peak potential, thus stopping the sodium inflow. So at one point, there will be a movement of so much sodium that it will reach a peak, and then it will decide to go down, okay? So after it reaches the peak, the sodium channel will close, and there will be a potassium activation of the gate, and the gate will be open, and we will have potassium flowing outward, okay? So when the potassium flows outward, it's actually also positive. So when it goes outward, what is going to happen to the resting membrane potential? No, it's going outside of the cell, not inside of the cell. Exactly, when it goes outside of the cell, it starts to become more negative, okay? It goes down. Membrane hyperpolarization. Potassium activation gates are slow to close. So at this stage, the potassium has exited in a huge number, which will lead to the potassium channel to get closed and to slow down, which will lead to a humongous amount of potassium to go out of the cells. And at this stage, we call it hyperpolarization. Why? Because it's even more negative than usual. Okay, you are like at the stage that it's more negative than it should be. So we need to fix this. How to fix this? If you remember, there was something called the sodium-potassium ATPase. The sodium-potassium ATPase is going to regulate what is more outside, what is more inside, and it's going to fix that. So they write, membrane hyperpolarization. Potassium activation gates are slow to close at this point. Excess potassium efflux and a brief period of hyperpolarization. Next, at this stage, what will happen? Voltage gated sodium channel switch back to the resting state, and they write sodium potassium bomb restores the ion concentration, which what they do, they bring the potassium from the outside to the inside against concentration gradient. That's why they require ATP. And they take the sodium from inside of the cell to the outside of the cell. Why? To maintain the resting potential again. Okay, so that is basically the neuron action potential. So the depolarization, the resting membrane potential mediated by potassium, actually the sodium potassium ATPase, but mainly the potassium. Depolarization itself is sodium mediated. The repolarization is potassium mediated. If you take a look at the blue line, you can see at this area where we have the depolarization, sodium permeability was high. When the area of repolarization, potassium permeability was higher. Okay guys, so I will see you in 10 minutes. Okay everybody, welcome back. So let's continue. Now the next portion of this first aid, I have to say this is one of the annoying parts because it's zero understanding. It's 100% memorization. So just try to do something, anything that will help you to memorize. So sensory receptors. Different type of receptors that are located in the skin have different type of sensation. So if somebody has no skin, can he sense? The answer is not really. Okay, so free nerve endings. So you can see there is the alpha and the delta. The fibers, they are considered fast, while the C is slow. C is slow. While the alpha and delta airplanes, you know, delta flights, so delta planes are fast, but the taxi is slow. So why it's faster? Because it's myelinated. Why it's slow? Because it's unmyelinated. So the myelination makes it faster. Why? Because it helps it to move and jump between different neurons. From neuron 1 to neuron 2, how do we move? By jumping, using the node of Ranvier, if you remember. So let's take a look. They say senses include pain and temperature. Pain and temperature. All tissue except cartilage and eye lens. Numerous in the skin. So wait a second. So are they telling us that the cartilage and the eye lens don't have sensation? I mean pain sensation? Well, mostly actually, yes, well, they don't. However, inside of our skin, like a skin, we do have it. Because of that, the pain is mostly located in our skin. So if the patient gets a deep burn, not a superficial burn, but a deep burn, and he burns his free nerve endings, will he be able to sense pain and temperature anymore? If he burns his nerve ending? Okay, so no, exactly. At deep burn, there is basically impossibility to sense the pain. Okay, good. The next thing they say here, let's see. They say free nerve endings, we discussed that. All tissues except cartilage and eye lens, numerous in the skin. It's for pain and temperature. Myciner corpuscles, myciner corpuscles, they are large myelinated fibers and they adapt quite quickly. And the idea in these guys, the myciner corpuscles, is the following. They are responsible for the dynamic and the fine touch, and the fine and the light touch. What is the fine and the light touch? You know when you sense something and you say, oh, this is soft. Or you sense something and you say, oh, no, this is harsh. The thing that help you to tell it's soft, it's harsh, something like that, it's actually the myciner corpuscles and low frequency vibration. Also, it helps you with the position sensation and skin indentation. So when some type of, some people have harsh skin, some people have smooth skin depending on their profession. For example, somebody who works as a worker tend to have more harsh hand skin than someone who works in an office. So this different sensation on a handshake, for example, this is all maintained by the Bassinian corpuscles. And it's found mainly the Bassinian corpuscles where on the hairless skin. Where we have hairless skin? Give me two places in the body in which we don't have hair in our skin. The palms and the soles. The palms and the soles. Okay. The Bassinian corpuscles. The Bassinian corpuscles are for the high frequency vibration. Contrast that with the Bassinian, which was slow. Okay, and also the breccia. However, all of these different types of sensory receptor, I will show you them. You don't have to know how they look like, except one, which is the Bassinian corpuscles. They actually require from you to know the histology of the Bassinian corpuscles and how to identify it on that. So let's take a look at it. It has an onion-like shape, we call it, as you can see here. So this is the Bassinian corpuscle, and you can see it has this onion-like shape. They might show you a picture of this, and they tell you then what is this responsible for? The correct answer, it's a pressure and vibration. Okay. Remember, high frequency vibration and the pressure. They mostly will ask about the pressure and vibration, just they will put them next to each other. The Merkle disks, they are large myelinated fibers that adapt quite slowly. Also Ruffini adapts slowly. So Merkle and Ruffini, both of them adapt slowly. So for the Merkle, it's located at the fingertips and superficial skin. What is the idea of this? Let's imagine that you have, let's say, a key in your bucket. And you tell me to put my hand in your bucket and feel it. So when I put my hand in your bucket, I try to feel it and I tell you, oh, it feels like a key. So I felt the shape of the object and the edges of the object, right? We call that deep static touch. Or you have a spoon in your bucket. When I put my hand in your bucket, I feel a spoon, right? The same idea. So these two different types of sensation are considered as, deep static touch. Okay, the next thing we have the Ruffini corpuscles. The Ruffini corpuscles, they are large myelinated fibers and intertwined among collagen fibers bundle, and they also adapt slowly. The main idea about these is to know where they get activated, which is during stretch and angle change. So they can tell you basically, did somebody pull your hand, for example, okay, or twist it? That's the Ruffini tell you that. So it's at the fingertips and in the joint. If I was you, these are really annoying to memorize. I would memorize that myelinated are the alpha and delta. Unmyelinated are the C, fast and slow, both of them for pain and temperature. I will know that the free nerve ending is for that. I will not worry too much about the Bassinian, Merkle or Ruffini, but I would master Bassinian corpuscles because they do ask about this. The next thing is about the peripheral nerves. And can you tell me what myelinate the peripheral nerves? The Schwann cells. So a peripheral nerve, if it was without the Schwann cells and you are just looking at it, it has the following layers. It has something called endoneurium, perineurium, epineurium. The endo, it's the innermost thing, as you can see here. They write, thin supportive connective tissue that ensheath and support individual myelinated nerve fibers. So you are like, oh, so this is the nerve, so the Schwann cells are here. No, they are not. Okay, so this is the nerve and the Schwann cells are on it. Okay, so this is the fiber and the Schwann cells are on it. Yes. Okay, so the Schwann cells are on the nerve fiber inside of the endoneuron, and they can be affected in case of Guillain-Barré syndrome. Why? Because Guillain-Barré syndrome destroyed the Schwann cells. Perineurium, it is for a blood nerve permeability barrier, it's around a fascicle of nerve fibers. So it helped to surround a fascicle of nerve fibers. Okay. The last thing is epineuron, which is a dense connective tissue that surrounds the entire nerve, a fascicle and a blood vessel. Okay, good. So we have the endo, peri, and epi, 3 types. Good. They like to ask you only about the endo. Why? Because they want you to imagine in Guillain-Barré syndrome which one will be affected. Chromatolysis. Let's cut somebody nerve. If you cut somebody nerve, it highly depends. Did you reconnect it or you did not reconnect it? If you did not reconnect it, you will have Valerian degeneration. If you reconnect it, you will have regeneration. So in this case, they like to mention that you did not connect it back. So chromatolysis. Reaction of neuronal cell body to axonal injury. Let's say that there was a nerve, you cut it, but you did not reconnect it to place. So what will happen? Changes reflect increase in the protein synthesis in effort to repair the damaged axon. So what will happen? So when the soma of the cells, which is the cell body of the nerve, feel and sense that there was a cut here, she will be like, okay, survival mode, everybody. Let's start trying to survive. So the first thing first, there will be swelling of the soma. Why? Because it's going to overproduce proteins that are required for the synthesis. So it's going to become a little bit more buffy, as you can see in this picture. The next thing will be displacement of the nucleus to the periphery. Why? Because it will be pushed aside by the Nissl substance. What is Nissl substance? Does anybody remember what was the function of Nissl substance? Yes, it creates the transmitters, absolutely. The Nissl substance, if you remember, it was used to make the neurotransmitter, and it was basically the rough endoplasmatic reticulum, right? Okay. So the next thing, let's see. They write displacement of the nucleus to the periphery, dispersion of the Nissl substance throughout the cytoplasm. As you can see here, it's all over the place, it's dispersed. So Valerian degeneration will happen distal to the cut, as you can see here. So they write, disintegration of the axon and myelin sheet distal to the site of axonal injury with macrophage removing the debris. So after the cut, everything after that will have Valerian degeneration, and the macrophage is going to eat it. Who is the macrophage in the CNS? Who is the macrophage in the CNS? Come on. Microglia cells. Okay. So it's going to eat up whatever debris are left. Proximal to injury, so it will be like right here, exactly after where the injury has occurred. And they write, proximal to injury, the axon retracts and the cell body sprouts a new protrusion that grows towards other neurons for potential re-innervation. Okay, so this one is cut, but there is an additional nerve here, so this will try to connect here and here. Well, this thing is not perfect, as you understand, so it will not be 100% perfect, but in the CNS, and especially in the CNS, it's amazing. Why? There is something known as the one second, neuroplasticity. What is neuroplasticity? It's this thing. You know, somebody gets a stroke. He cannot speak, he cannot move, he cannot do anything. And you know, his neurons are dead for good, because that's it. The nerves will not become alive again. So how the hell he can speak again? You know, after physical therapy and stuff like that, he can regain a little bit of his function. So how this is even possible? So the reason that this is even possible is that it is because like the surrounding areas of the damaged area are going to start working its function. So they are going to start to do the same function of that last portion. So they write, proximal to the injury, the axon retract, and the cell body sprouts a new projection that grow towards the neurons for potential re-innervation. Serves as a preparation for axonal regeneration and functional recovery. So neurotransmitter changes with the disease. So which disease associated with which neurotransmitter? Acetylcholine, first of all. So the acetylcholine is produced by the basal nucleus of Maynard, which is located at the forebrain. I have to show you this. Okay, here it is. Oh, I like this picture. It's all of the structures are here. The hippocampus is responsible for your memory. The amygdala is responsible for your emotion. Okay? Here you go. Okay. So, in Alzheimer's disease, acetylcholine is low. And that's why, if you remember, we spoke about the galantamine, rivastigmine, and this medication, which used to increase acetylcholine in case of Alzheimer's disease, and that used to, improve the symptoms. In Huntington disease, if you remember, there was something called the CAG, right? This was the trinucleotide repeat expansion. I just remember it because it in Huntington disease, you hunt and then you put it in the cage, okay? So CAG. CAG, if you remember, in this patient, they had reduction of acetylcholine and reduction in GABA. Okay, so Parkinson, they will have more acetylcholine. That's why we utilize medication such as benzotropine and trihexyphenidyl, which are antimuscarinic medication in Parkinson's disease to improve the symptoms. Dopamine. Okay. In which patient do we have a lot of dopamine in the brain, except schizophrenia and Huntington disease? The answer is psychopath. Psychopathic patients tend to have a lot of dopamine, especially in their frontal cortex. Our frontal cortex is the cortex that is responsible for our behavior. So yeah, that's important. Okay, does anybody know, this is a little bit of psychiatry, we will eventually speak about this, but really quick, there is somebody called sociopath and there is a psychopath. These are totally different from each other. A sociopath is stupid. He is the type of person that goes to jail. He is impulsive, do like crimes, kill, steal, do impulsive stuff, you know, and he end up in jail. A psychopath, however, is super smart. He actually is more smarter than average people. A psychopath has only one problem. Oh, actually, he's full with the problems, but his main problem that he does not have emotions for the people. So whatever he does, he's just acting it. Okay? So a psychopath is a dangerous type of a human beings. Okay. How many psychopaths of the population do we have? What is the percentage of psychopaths? The percentage of psychopaths in the normal population? No, come on, 10% is too much. It's 1%. It's 1% of the whole population are psychopaths. Which are the two main fields that have a lot of psychopaths in them? I'm not kidding. This is actually like something you have to know about. Which are the two professions in which we have a lot of psychopaths? Surgeons. Actually, it's kind of true. Physicians, doctors, and the next one is politicians. Politicians, like somebody did a study on this to check what is the percentage of politician with a psychopathic behavior. He found it was 30-something%. And in physician, it was 4%, which is actually the next high. Okay? So how come doctors who are psychopathic, there is more doctors who are psychopaths than general population? Basically because psychopaths are smarter. Yeah, Putin could be one, because basically the absence of emotion. The absence of emotion equals psychopath. Interesting. So, are you telling me that a psychopath, if he, he will not feel any type of guilt if he harms somebody? Not at all. Exactly, exactly. So, dopamine. Dopamine is made in the substantia nigra and in the ventral tegmentum. Both are located in the midbrain. So, in depression, dopamine will be down. That's actually one of the main causes. Like in depression, dopamine is down. And if you remember, we can give the SNRIs or SSRIs, which are type of medication that increase the serotonin and they increase the dopamine. Schizophrenia, the dopamine will be high. That's why the antipsychotic works. Okay, wait a second. So if we bring a patient that does not have a schizophrenia, normal human being, and we load him up with L-DOPA, which is the precursor of dopamine, which eventually is going to increase the dopamine, can he have hallucination, which are existing in schizophrenia? Absolutely, yes. So people who are like even not psychotic at all, but you give him plenty of dopamine, he's going to develop basically hallucinations. Does it mean everybody who has hallucination have schizophrenia? No. Can a normal human being have hallucination under severe stress? Okay, that's correct. If somebody have, yeah, that's true. But when we speak about hallucination regarding psychiatric illness, is it visual or auditory most of the time? Okay, in case of psychiatry, it is going to be auditory in schizophrenia. But if it was medically induced, it will be visual. So medication lead to visual hallucination. Auditory hallucination are in case of psychological disorders. You are like, wait a second, but is schizophrenia, in case of schizophrenia, how can we say? What is the problem in schizophrenia? They hear voices, okay? So, but you hear voices, all of us hear voices all the time. I mean, you go to the supermarket and think, did I turn off that heater? That's a little bit of OCD, but anyway, you hear voices that always speak with us, you know? Oh, I should take out the garbage, I should do that, I should do this, I should So what makes the difference between you and the patient who's a schizophrenic? In a schizophrenic, they hear the voices at the wrong time. You know, that's the main problem. And the voices are not friendly most of the time, which make these patients quite scared. They can be voices like "go kill yourself," or voices like "jump," you know. So yeah, that tend to be a little bit more serious. Anyway, all of this and more we'll be discussing in psychiatry, which is like a topic really interesting that will be after neurology right away. In Huntington disease, the dopamine will be increased, and in Parkinson, it's going to be decreased. That might explain why a Huntington disease patient also do have hallucination, and also they are violent. They are really, really violent. So the next thing we have is GABA, which is produced by a nucleus ambiguous, which is located in the basal ganglia, and it is quite decreased in anxiety. Remember, GABA is in the inhibitory neurotransmitter. So when the inhibitory neurotransmitter is down, you will feel anxious. Okay, Huntington disease, it's going to also be like disinhibited, this patient, and it's going to be quite aggressive. So their GABA is down. Norepinephrine is produced by the bones in an area called locus ceruleus. I know that the names tend to be a little bit difficult to memorize. I have some tricks. I don't know if you would like to know them. I can give you one of them, for example, here. So norepinephrine, it's like North Korea. So north, as you can see here. So North Korea is quite serious, ceruleus, okay? So yeah, if that works for you. If you watch the Teenage Mutant Ninja Turtles, maybe you know Raphael. Raphael is a character in the TNMNT, which is like Teenage Mutant Ninja Turtle. And he had a weapon. Does anybody remember what was the weapon of Raphael? The psi, excellent. So he had the psi, this guy, right? He had the psi. Where is he? Yes, this guy, and he had the psi. So that's why I remember that Rafi nucleus have serotonin, right? The psi is serotonin, and his Rafi nucleus. So that's just some of them. The other ones are easy, but like you need to know few so you can, well, guess the others. So yeah, anxiety will have more norepinephrine in it, while depression will have less of it. Serotonin, however, will be low in anxiety and low in depression, and also low in Parkinson's disease. So yeah, the hormones that make you happy are dopamine and serotonin. Okay, so when we say somebody is madly in love, which hormones are working? Can you tell me which hormone are working in case of love? Okay, oxytocin is one. What else? Endorphin a little bit, yes. You know, okay, let me actually tell you really quick what is every one of them do. It goes something like this. Oxytocin make us feel bound to that person. Okay, a quickie question. Is it more in ladies or in men? Oxytocin. Women have more oxytocin than men. That's why men tend to be more of a cheater, while women are tend to be more loyal. I'm not saying always, but most of the time. Okay, so what about, you know, when somebody is madly in love, especially in the beginning of love, and he sees that person and he has this butterfly effect inside of his abdomen? What is that? The butterfly effect inside of the abdomen. What is it caused by? Well, it's actually norepinephrine and serotonin, probably gases as well. Anyway, the next thing is dopamine. You know, when she see him, she feels so happy. That's dopamine. Okay. So a combination of these hormones, this is basically love, the portion of love. Yep. Okay, so it's pure biochem. So the meninges. So the meninges, remember, we have the pia mater, the arachnoid, and the dura mater. Three membranes that surrounds and protect the brain and the spinal cord. So they cover both of them. Dura is durable. If you remember, I told you about it yesterday. I said dura is durable, so it means it's thick, strong, and heavy. So thick outer layer closest to the skull is derived from the mesoderm. So the dura is durable, derived from the mesoderm, and it's going to be quite strong. So the next thing they write about is the arachnoid. Arachnoid means a spider-like net. So in the arachnoid, it's the middle layer, and it contains a web-like connection. Arachno in Latin means spider. It's derived from neuronal crusts. So let's say that you are going to stain it. It will stain positive too. S100, yes. Okay. The pia mater is thin and has a fibrous inner layer that firmly adhere to the brain and the spinal cord. It's like this jelly layer that is located on the brain himself. It's derived from neuronal cross cells, okay? From neuronal cross cells. So the CSF flow in the subarachnoid space is located between the arachnoid and the pia mater. The CSF. So that's also the blood vessels in the brain are located at the subarachnoid space. That means that inside of the subarachnoid space, the blood vessels are swimming within the CSF. In the epidural space, however, it's a potential space between the dura mater and the skull. To be truthful with you, it normally almost does not exist. Why? Because there should not be a space there. It should be just connected to each other. So why we speak about it? Because sometimes it can fill up with the blood. Okay, potential space between the dura mater and the skull / vertebral column, containing fat and the blood vessels. Not the blood vessels of the brain, however. It's the blood vessels of the meninges, the dura mater. Sites of blood collection associated with middle meningeal artery injury. Okay, so that's an epidural hematoma, which is most commonly due to trauma. The blood-brain barrier. Okay, so the blood-brain barrier, it prevents circulating blood substances such as bacteria or drugs from reaching our CNS. Okay, that's a good thing, right? It protects our brain from being exposed into, bad stuff. Do we have other barrier inside of our body except the blood-brain barrier? Yeah, blood what barrier do we have except of the blood-brain barrier? Do we have any other barrier that we have a blood something barrier? So we actually do. We have the, yes, blood placental barrier and the hematotesticular barrier, hemato-ovarian barrier. Hematotesticular barrier is super important. Why? Look, guys, if somebody gets a really bad hit in his testicles, just a kick in the nuts, and his nuts, well, I hate to say that, but they are going to break. And not to break because they are spongy, but they are going to be damaged. And when they get damaged, few sperms can enter his blood supply. You're like, not a big of a deal. Is it big of a deal if a man's sperm enter his blood supply? It is. It is. Why? Because normally he had this hematotesticular barrier which would prevent any sperm to enter his blood. Now, if the sperm enter the blood, how the blood is going to kill it? You are like, well, it's not big of a deal. The macrophages will come and attack it and eat it. Yes, they will do. And remember, macrophages are antigen presenting cells. So they are going to present the proteins located on the sperm to the T cells and then to the B cells. And the B cells are going to convert into plasma cells. And the plasma cells will do what? What will the plasma cells do? Antibodies. Antibody against who? Against the sperm. Exactly. So if we have antibody against the sperm in a man, that will destroy his sperms. Can he have children? No. That's why, for each man out there, be careful. Don't get hit in the nuts. Your future will be gone. That's what it literally means. I told you the whole story now. Okay, so you still make semen, but it's spermless or dead sperm, which means that it's really serious. And actually, it's kind of really difficult even in IVF. In IVF, when they do it, they take all of the sperms, but they look for the most alive ones to inject. Okay, tight junction between non-fenestrated capillary endothelial cells. So first of all, we have the endothelial cells, which is inside of the blood vessel, inside of the capillary. Then we have the basement membrane. Then we have the astrocyte photoprocesses, which was the most prominent cell. And finally, we have something called the pericyte. What is the pericyte? The pericyte is a type of cells that keep other cells together. Also, we have something called the tight junction. Tight junction is like a sealing type of connection in which it prevents the two cells from going away from each other. Just literally suture them together. Glucose and amino acid cross slowly by carrier-mediated transport mechanism. So yeah, they just are going to go in, amino acid and the glucose, because the brain does need them. Non-polar lipid-soluble substances can also cross easily. So you're like, nice. So you are telling that if somebody has some type of lipid-soluble medication, it can go directly to the brain? The answer is yes. What about hydrophilic particle? No. Lipophilic? Yes. Hydrophobic? What do you think? Hydrophobic will go to the brain? Yes. Hydrophobic is the same as saying lipophilic. Okay, circumventricular organ with fenestrated capillaries and no blood-brain barrier allow the molecule in the blood to affect the brain function. So there is circumventricular organ, which are little organs located really close to the ventricular system of the brain. So they write, these guys allow molecules in the periphery to act on the brain. For example, we have an area called area postrema, which is located in the fourth ventricle of the brain. It's the vomiting after chemotherapy. Why? Because the chemotherapy is going to lead to the destruction of the rapidly dividing cells. And when which organ has a lot of rapidly dividing cells, and that organ also produces serotonin, which stimulate the area postrema? The intestine. Good. So the intestine, actually normally they are the organ that produce the most amount of serotonin. Remember, in the brain we also have serotonin production, but in the intestine basically we just have more. Okay, so when the intestine is going to be destroyed, a lot of serotonin is going to be released, and when they are going to be released, that's going to lead to what? They are going to activate the area postrema, which is going to lead to the problem. Okay, so we also have organ vesicularum lamina terminalis, which is an osmoreceptor, which reacts to what? It reacts to the osmolality of the blood. Okay, well, what does that mean? Well, if the blood is hyperosmolar, you need to dilute it. How can I dilute the blood? By reabsorbing more water. And what is the hormone responsible for the reabsorption of more water? Antidiuretic hormone, absolutely. Okay, so they write, or neurosecretory products to enter the circulation, for example, neurohypophysis, can lead to ADH release, which is the posterior particle of it. Infarction and neoplasm destroys the endothelial tight junction, which is this guy, the tight junction, which can lead to vasogenic edema, which is important. The story will be somebody who got some form of hemorrhage in his brain, and then they ask you, oh, now he has an edema of his brain. Why this happened? Because the cell tight junction was gone. Okay, they also write hyperosmolar agent like mannitol can disrupt the blood-brain barrier by why? Because increase the permeability of the medication. Okay, so the mannitol can be actually utilized for brain edema to take out the water osmotically from the brain. Vomiting center. It's coordinated by something known as a nucleus tractus silotorius in the medulla, which receives information from chemoreceptor trigger zone. So I just would like to show you this structure in person. Okay, nice. So they write, all of this is mediated by something known as the nucleus tractus silotorius, which is an area located within the brainstem. Okay, nucleus tractus silotorius in the medulla. It receives the info from the CTZ, which is located within the area postrema. You can see here the CTZ within the area postrema, and they write bucostrema, postrema, okay, in the fourth ventricle. So the GI tract via vagus nerve and vestibular system, and also the CNS. The CTZ and adjacent vomiting center nuclei receive input from 5 major receptors, including the M1, dopamine, histamine, serotonin, and neurokinin. Which of them is the most important during chemotherapy? Which of the following is the most important receiver? Serotonin. Serotonin is the most important. Okay, so serotonin, why? Because in destruction of the intestine. So serotonin, dopamine, and neurokinin antagonist used to treat chemotherapy-induced vomiting. The most important one is serotonin. Remember, it binds to the serotonin 3 receptor. However, the H1 and the M1 antagonist used to treat motion sickness. What is motion sickness? You know, when you are in the sea and you get this dizziness, you know, and you want to vomit. That's motion sickness. H1, and the most commonly used drug is a drug called Discobalamine, which is an M1 antagonist. H1 antagonist can be used for hyperemesis gravidarum. So, you know the ladies in the movies, how does she know that she's pregnant? She starts vomiting a lot. Okay, is that real? From the movies, like when they make a lady that, oh my God, she's pregnant and she starts vomiting like hell. Is that true? It's not always, but it is kind of true. Why? Because the beta HCG actually stimulate the chemoreceptor trigger zone. Like, really? The one for chemotherapy stuff? Yes. So the beta HCG can directly stimulate the area postrema inside of the brain, leading to the vomiting. So poor ladies actually are forced to vomit, which is quite difficult. We call that hyperemesis gravidarum. Most likely in the first trimester. If the lady is in her third trimester and she's telling you, oh, I have this horrible vomiting, probably she's just lying. But yeah, first trimester is true, it sucks. And but in the second trimester, be prepared for the hormonal stuff because they increase significantly and she becomes more crazy. So that's also important. Okay, guys, I'm going to call it off now for here, and I will see you tomorrow at the same time. Goodbye, everybody.